Great. So the vast majority of you got that right. So gabapentin is the correct answer. She is having post-herpetic pain, which is characterized as a neuropathic pain. Agents meant to treat neuropathic pain are the most effective. Ibuprofen can be helpful, but it's more helpful in kind of the acute phase of the rash when patients are also having somatic pain. It could be considered a second-line agent. Prednisone, again, may have a role in kind of the acute phase of the rash when there's a lot of inflammation, but is not effective for treating post-herpetic pain. And opioids are really considered kind of third line. Opioids are not as effective for neuropathic pain and don't have as much of a role in treating post-herpetic neuralgia. All right. So when we think about pain, we kind of bucket it into acute, chronic, or subacute. So acute pain is lasting less than 6 weeks in duration, chronic pain 3 months or more, with subacute sort of fitting in between those two. As you guys know, we can further subcategorize pain based on where we think the source of the pain is coming from. Nociceptive pain is characterized by tissue damage or inflammation. We can further characterize that into visceral or somatic pain. If you remember, visceral pain localizes to your internal organs. It tends to localize poorly, and it can be described as cramping or aching pain. It feels deeper to patients. Whereas somatic pain may be described as sharp, stabbing, or throbbing. It can be due to musculoskeletal or inflammatory causes and tends to be somewhat more superficial, involving the musculoskeletal tissues. Neuropathic pain is often described as burning, electric, prickling. Patients may have associated neurologic deficits, they may have paresthesias, they may have associated loss of symptoms. Central neuropathic pain can be due from direct damage to the central nervous system, particularly in the instance of spinal trauma. But more commonly, central pain is secondary to dysregulation of the neuropathic system. We can have a hyperresponsive system in patients who have chronic pain, and they can start to interpret lots of different stimuli as painful. So you can have phenomenon like hyperalgesia, so something that would be mildly painful, like a pinprick, may be devastatingly painful to patients who are experiencing this. Allodynia, this is the term we use when patients have pain as a response to a benign sensation. So for instance, combing your hair may be perceived as painful. This is thought to be due to a process called temporal summation. So if you guys recall, back from medical school or the last time you thought about this, there's a presynaptic neuron and a postsynaptic neuron. Temporal summation is the idea that the presynaptic neuron is being stimulated in a pattern repetitively such that it ends up giving a huge response in the postsynaptic neuron. So what would normally be kind of a benign stimuli all of a sudden becomes this really exaggerated response. And over time, that's what can lead to this CNS dysregulation. There's also this evolving concept called opioid-induced hyperalgesia. This is the thought process that patients on chronic opioids actually start to have a paradoxical reaction where when the opioid is out of their system, the nerves become more sensitized to painful stimuli. This can lead to a vicious cycle where patients complain of more pain, their opioids get increased, and it increases the hyperalgesia. So just something to consider in a patient who's on chronic opioids and presenting with worsening pain, that this could actually be the culprit rather than a progression of their chronic pain process. In patients with chronic pain disorders, the pain is usually from multiple etiologies. And the instance of substance abuse and other mental health disorders like depression and anxiety is very, very high in patients with chronic pain. So it's always important to screen for and treat for those conditions in addition to treating the chronic pain. First-line treatment for chronic pain is always non-pharmacological. Again, we want to look for and treat mental health issues that may be contributing. Physical therapy and exercise are incredibly helpful for treating pain. Physical therapy can address specific processes. So for instance, in sciatica, where you can stretch and open up kind of the compression of that nerve. Exercise itself can be helpful for chronic pain just because of the production of endorphins and because motility can help to improve a lot of musculoskeletal issues. Other non-pharmacological things that have a lot of evidence to support them are CBT, mindfulness therapy, and biofeedback. In addition, massage, spinal manipulation, or chiropractic, and acupuncture have variable evidence to support them, but certainly have no risk of harm, so they're a great thing to encourage in patients who are open to them. When we think about pharmacological therapy for chronic pain, first line is always acetaminophen, and in patients without contraindications, we think about NSAIDs. Remember, these medications do have a ceiling effect, so you can only get so much pain relief from Tylenol and ibuprofen. Topical anesthetics are a great option that are often underutilized. We have lidocaine listed on here. There's also things like topical diclofenac. Capsaicin can be particularly effective for neuropathic pain. In addition, the gabapentinoids, so gabapentin and pregabalin, are first line for neuropathic pain, as is the SNRI duloxetine. Tricyclics are the other class of medications that have some evidence to support their use in chronic pain, but remember, tricyclics are often limited because of their side effect profile. They have a lot of cardiac effects, and in older adults, these are highly anticholinergic, so relatively contraindicated. As we already discussed, most chronic pain is multifactorial, so we really want to concentrate on a multimodal approach. In patients that have failed all of the other things that we discussed, there is a role for opioids. This is obviously a topic of huge concern and discussion that continues to be ongoing in this country. There is no evidence that supports opioids long-term, so if we have to use them, it's important to use them in the lowest effective dose, ideally with a plan to eventually titrate them off. If we are prescribing opioids for chronic pain, it's best to be prescribed from a single provider under a pain contract or behavioral contract. They should be regularly screened for use to ensure that they're not diverting. It may be appropriate to periodically screen them for other recreational drug use. Again, I'll remind you of the opioid-induced hyperalgesia that can occur, so something to look out for in patients on chronic opioids who are having increasing pain. Benzodiazepines are relatively contraindicated in patients on opioids because of the risk of respiratory depression. And in any patient who is being prescribed chronic opioids, it is vitally important that we also have a safety strategy and prescribe them some form of naloxone, as well as providing education on use. All right, we're going to switch gears here. A 24-year-old woman is evaluated for cough of 4 weeks duration following a typical URI. Her upper respiratory symptoms improved, but she is now having paroxysmal cough with post-tussive emesis. She works in daycare, and her physical exam is normal. Which of the following is the most likely diagnosis? Cough variant asthma, GERD-related cough, pertussis infection, post-infectious cough.